Yeah, if you don't mind, I only have one, so
That's
pretty
fine.
quick.
I'll make you presenter.
You guys see the screen?
Yep, we're good.
Okay. All right. So this was kind of a case I had recently on a tumor board, and the story is, I don't have all the prior images, but the story is that this was a mediastinal mass that was seen a few years ago on a calcium score CT, and I don't have the initial because of the outside hospital. I don't have the initial CT, but it was unchanged from. This is what it looked like. This is a more recent PET CT. So it's a well circumscribed anterior mediastinal mass seen incidentally in a calcium score patient, asymptomatic. It was presumed to be at the outside facility. It was presumed to be it was suspicious for a thymoma, and they actually went in. I'm not sure exactly what workup was done, but they went in surgically, and they took out the thymus supposedly, and that was normal. They didn't see anything, and then this lesion, they left it in there because they thought it was in the pericardium or within the epicardium, so they didn't want to touch it. And then it was followed for a few years later, including it got transferred to our institution. It was stable, and it looks like it's kind of tracking along the pericardium, and the thought was that it might be some kind of epicardial cyst. Pericardial cyst. But it was well circumscribed and stable, so presumed to be benign. Recently, he got more workup, and he got a PET CT and a cardiac MRI. And then this is the PET CT, stable size. I was having trouble getting the anonymizing the PET images because they had PHI over them. But if you could take my word, it was just, so there was blood pool FDG activity over this lesion. So didn't really quite make sense for a pericardial cyst. And then recently there was an MRI, a cardiac MRI actually of it. Here's the lesion, here's a T2, so very bright on T2. Sorry, this stuff is a little out of order here. And this is on perfusion. Let me actually. So this is a T1, so bright on T2 and dark on T1. So it makes sense for a cyst so far, but if you look at the perfusion images, so dynamic perfusion, you start seeing some contrast here, and here's another perfusion scan. You can clearly see enhancement on early arterial enhancement here superiorly along the mass. And then if you look at the some of the delayed enhancement images, you can see it's starting to fill in. So nodular delayed enhancement on the later images, and becomes more homogeneous. So I thought it was a pretty nice look for a mediastinal hemangioma.
That's a nice case. That's a good example.
Yeah.
What was it involving? I mean, it was right on the pulmonic valve on that MR. Was it mediastinal or was it intrapericardial?
Hard to say. I'm not sure.
I mean, because on the MRI you showed where it showed the pulmonic valve. I mean, it looked based on one of those images, pretty, yeah, right there. I mean, it's got mass effect on the pulmonic valve. Could you tell from, I mean, for the MRI, you could see where it was the relation to the pericardium. I mean, there it looks intrapericardial, right?
Yeah.
I mean, anterior, isn't that pericardium anterior to that?
I mean, I guess there's pericardium here.
Oh, I was thinking there's pericardium actually, the anterior line
Yeah.
by the right atrial appendage
Might be
is
with
pericardium.
Yeah.
I think this is intrapericardial. I think this is,
Yeah.
I don't know, you have all the MR images, but, because that's a very different, if you're going to take it out, that's a very different surgical approach.
No, I don't think they're going to take it out. They're just going to keep because the patient's completely asymptomatic and it's been stable for years.
But on your perfusion, you should go back to the perfusion because you're sagittal, because there you see you should be able to see the pericardium really well as well, or any sagittal.
Let me
Yeah, there I'm not sure. I can't see the pericardium well. Anyways, it would be something to look at to see.
I didn't read I didn't put too much into that because I was just on a tumor board, and the question was what to do with it. So I think just the decision was that nothing needed to be done on this one. Either way.
Okay.
What was the reason for the PET since it hadn't grown? Was there anything particular they were looking for?
I think because so I guess when the read on the MRI was kind of unclear, and then there's a few different diagnoses were suggested, so they just wanted another data point.
Okay.
I think a lot of people had been calling it a pericardial cyst, but then they saw where they were reading the cardiac MRI, they saw that the enhancement, so it was kind of went back and forth. So maybe it's not a cyst. Decided to get a PET, and then just putting it all together.
Okay.
I think once everything looks like a hemangioma.
Well,
But yeah, that's a good point. I think it is. It looks like, it definitely looks like it's in the middle of the pericardium. That's probably why they didn't take it out initially when they went in surgically at the outside hospital a few years ago.
yeah, like what you described, it sounded like it was not separate from it, so they didn't want to go poking around in it.
Yeah. Yeah, so I guess not a mediastinal. Yeah, better to describe it.
So they got the thymus out. Yeah, that thing would have.
Yeah.
Right next to it. Or.
Yeah.
Oh, cool. Well, that's really neat. I can't remember if I've seen, we've seen pericardial parathyroid adenomas, and then we've seen a couple of big paragangliomas, but they're so big they sometimes, who knows where they start from. But I don't think I've seen a vascular malformation type thing in the pericardium.
Yeah.
All right. Well, thanks, Peter.
Thanks, guys.
All righty, Seth or David?
I mean, I can go if you want.
Yeah, we got plenty of time today.
1 second, let me increase my screen size. Okay. Get rid of all this other junk. Oh, okay. Anyways, well, the first I'll start with, this is just the case we had yesterday, not very nice example, just not diagnostic dilemma. So this patient has this aorta is about 6.5 centimeters, so pretty big, but it's just a very nice example. It's a little bit different than some of the other flow-related artifact, which was along the inferior aspect of the aorta. Although some of it is along the inferior aspect. This, you can see, is relatively decreased. Very good at pacification by ascending aorta. You can see there's a slab here, and then a lot more mixing artifact in the arch and descending thoracic aorta. Showing this around, I just thought it was a nice example of kind of smoke, or, this other one that we had many years back that we wrote the smoke paper on was more hugging the inferior aspect of the wall, the more anterior inferior aspect, that was kind of called this quote unquote Davis effect. Someone wrote a paper on it recently, but I don't know if this would be the same effect. I think this is just kind of mixing versus a flow related phenomenon, but just a nice example of kind of the wispy mixing of contrast in a very dilated aorta. So this is, now come on, man. But here, let's try to get all these these up at the same time. And maybe it will let me, let's see. I don't know why it's loading 4 things. It's probably loading the last case too. Anyways, I'll just do it one at a time. So this is a patient we saw the other day. I think I had this when I was on call. It was a very interesting, kind of window it and sharpen it a little bit to kind of show very interesting pattern where you have this really pronounced peribronchiovascular ground glass. The airways are very distorted. I don't know if I call them bronchiectatic. They're just irregular. They're thickening, they kind of get small and then large again. But there's all these kind of peribronchiovascular ground glass opacities here. And was actually not, honestly, when I saw the diagnosis, I really wasn't thinking of this entity. But I'll just slowly kind of scroll through it. And I'm curious if any of you guys would come up with what this was off the bat. I mean, the degree of airway abnormality kind of threw me off, and I'm still would love to know what the exact airway abnormality was secondary to. Here's a more kind of focal area consolidation. Here's an older study from 2015 where, so intermittently this patient would have an abnormal study. She was biopsied. They actually came up with the diagnosis. They would treat her, she would get better, and then lo and behold, at some point she would get worse again. And here you can see much more striking, really peribronchovascular ground glass, some areas of even more dense thickening of the peribronchovascular interstitium, some scattered nodules too. This case, a little bit more maybe able to get the diagnosis, but still I think hard to get. And then here is the intermediate study. So they biopsied this, and this was all a granulomatous angiitis. Here, another peribronchovascular consolidation. Here is more nodular. And they basically said this was classic for GPA, even though the patient was, the ANCA was mildly positive, but she was P-ANCA positive. But we know that, or at least the data says that, I don't know, 10, 20% of people with GPA are P-ANCA positive and not C-ANCA positive. And then another 10% of people with GPA are ANCA negative. So I always just find it very confusing when the ANCAs don't follow the underlying process. I just don't, you know, because this looks very different than the MPO kind of P-ANCA associated vasculitis. But I don't know, what do you guys, and it was interesting, I actually looked, Jane Coe published an article, a review on peribronchovascular stuff, and has a case of, another case I think of P-ANCA positive GPA that looks identical to this nodular case with the airway distortion. And I don't really know what the regularity of the airways is secondary. If is it the inflammation due to the adjacent vessel causes some form of inflammation to the airway? Do you guys have any thoughts?
I mean, they get tracheobronchial thickening stenosis too, so maybe it's just the same process further out in the lung. But I've seen 1 or 2 cases of GPA look more airway centered, like your case did.
Yeah, and this is, and I had this is the second case like this I've seen, because I remember I had an old case that I saw, I don't know, 8, 10 years ago that I pulled out of my own teaching files that looked like this, that was GPA. I'm sure people have done it, you know, the appearances of GPA depending on the positivity of specific antibodies, if it's any different or not. I'm sure someone's published that paper, but I don't know, that it was just an odd case. And then here's another case where I honestly, if I saw this, I would have said, okay, there's, you know, I don't know if I would call that a reverse halo sign, but there's some areas where you would call a reverse halo sign, and clearly very nodular. Some areas they're perilymphatic nodules, but again, I don't, in some areas it's really hard to delineate where these nodules are. I mean, here's a nice curvilinear kind of OP area. And this was another case of GPA that we had about, and this patient had a very, very high P-ANCA, or C-ANCA, sorry, and had characteristic findings of GPA supposedly, and it was biopsy that showed granulomatous findings. But it always, here's some more kind of perilymphatic nodules here, but it's always interesting to me the different manifestations of this entity. We always think of the classic kind of cavitary nodules, but I have to say I just don't see that frequently. A lot of times I see these more bizarre looks to it, and I don't think I would have ever come up with GPA looking at this entity. And then lastly, a case we had this week, where this patient had 3 CTs over a short period of time. Where this one's a little more, we were a little confused on this one because the initial study, we really thought this was going to be some form of septic emboli. I mean, very peripheral areas, low predominant. Some of these had little areas of cavitation in them, but and they told us initially that she was positive for Enterobacter or something. But in fact, her sputum was just positive for the bacteria, and she wasn't septic, and she was, afebrile, so that kind of put septic emboli out. And the very rapid changing in morphology of these nodules. And anyway, she came back, her C-ANCA, and then there's some P3 or something, I don't know what it is, some other test that's even better, supposedly for GPA, that came back very positive as well. So this is presumably another case of GPA, but all very, very different manifestations. But I really, all of them have some of this peribronchovascular stuff, or at least air bronchograms growing through the nodules, which, I always think initially when I see that, I think of maybe lymphoma or something like that. But yeah, this is another just case of GPA, but this one's a little more classic. At least you could maybe suggest a diagnosis based on the angiocentric distribution of these nodules. But it's just one of those diagnoses that I struggle with if it's not classic.
So Seth, in regard to your first case that really was looked like airways disease, I've seen several cases of GPA where I thought I was dealing with airways infection, and it turned out to be GPA. So I think it's probably inflammation coming from the adjacent arteriole that kind of surrounds
Yes.
the bronchus, and makes it look as if it's the center of the inflammation.
Yeah, and that's kind of my guess, because here's the artery running right next to the airway, and that the inflammation involves the whole peribronchovascular bundle, and you just get this. But I would love to see, this guy has path. I have to dig it up and see if our pathologists are willing to review with me to see if but the airways have gotten more distorted with age. He got biopsy back in like 2010 when the airways weren't that abnormal. So obviously they're not going to biopsy him again. But yeah, I'd be curious to see, like you said, I mean, we know that when you look at any lung biopsy, you see the arterial next to the bronchial, and I'm curious if there's like a concentric ring of inflammation and around the whole bundle versus, just centered on one or the other, like you see in most vasculitides or, airways processes.
Got it.
I don't know. I mean, no, your point, I agree with you. I think this is probably adjacent inflammation causing the irregularity, but I'm not sure.
But there is also inflammation. There are, I mean, of course, there's manifestations in the trachea too, right?
Well, those are larger airways. I don't know. I mean, this here, the large airways are completely normal.
Right.
It's involving more of the, more peripheral subsegmental airways. And I don't know. I don't know. I mean, that's a question. I mean, I know we all know about tracheal, central tracheal involvement, GPA. But I don't know if it can just involve the peripheral airways and spare the central airways. That's something it may.
Yeah, I remember a specific case very similar to this also, where it looked very much like airway disease.
Yeah. Anyways, Jeff, I just decided we had a couple of interesting GPA cases recently, so I kind of decided to show.
Yeah, no, it's fantastic.
Some of them.
It's a tough diagnosis. I mean, when you got nodules and cavities and masses, it's in the differential of tumor infection and GPA.
Yeah.
And we know that vasculitis can cause like the OP look, so that fit with that. But that case you showed that had the atolls, I was wondering at first if it was going to be like granulomatous infection where you get the
yeah.
sign, which is a variant.
I mean, I would never in a million years would I even put vasculitis in my differential here. But again, open lung biopsy, everything
be
is
like some mycobacterial disease or something.
Yeah,
that's cool. Yeah, it's a hard diagnosis, and we don't biopsy it much anymore because the antibody you referred to is anti-proteinase 3 or PR3, and you're right,
the one.
It's much more specific because the P ANCAs and C ANCAs can cross-react between the vasculitides. The ones that typically are like you don't get a lot of titers on are the ones that have limited like subglottic stenosis, but it's almost always positive when you have parenchymal disease. But
yeah, I think this one went to biopsy because they just weren't.
Yeah,
he had this non-resolving kind of process that everyone thought was some airway infection, and they brought, they did a big, I think a cryobiopsy or something, and it was GPA.
Cool.
Well, the airways have blood vessels in their walls too, so maybe it's the small vessels that are.
Oh, that's interesting.
Small airway in the walls of the small airways. It's really vessel size that puts it out there. So
yeah, that's interesting. Yeah, that's I'm gonna have to now start Googling pathology of the distal whatever, just to see if there's something out there. Okay, those are
all right.
My cases.
David,
I have one case.
Okay.
So this roughly 30-year-old person, young woman, has a mediastinal mass and has some lung nodules up here. These are TIFF images, so they're not as well behaved as the DICOM images. These had to be retrieved from the early 2000s. So here's our mediastinal mass and stuff like that. And we got a CT back then. They even had CT. And here is this big kind of lowish attenuation mass with some septations in it and a little piece of calcium. It seems to have the pulmonary artery embedded in it. The aorta goes into it, and pulmonary veins are being displaced by it. And I think there's pulmonary artery going into it too. Definitely aorta. Okay, and I can show you the lung nodules on a different scan. So very smooth lung nodules. And this is a case of, let me show you how things ended up. So this is like about 10 years later from our earliest radiographs. And at this point, there's been a bronchial stent placed. The nodules you saw on the right apex are larger, and there are more nodules than before. There's been, at varying times, left pleural effusion completely opacifying the left hemithorax. And this is all chordoma. So this is a thoracic chordoma. If we go back to the CT scan, there wasn't any clear disruption of the vertebral body. So I showed a case a few weeks ago of presumed chordoma. and there wasn't any vertebral destruction that was obvious on that. And I don't think there was on this person either. Certainly not visible on this scan. And the mass seems to be arising really centered in front of the spine, not clearly arising from spine, but this is chordoma. So it does share that feature with the case we had of lack of vertebral body involvement, which is known to occur with some cases of chordoma. So this one is proved. The other one that I showed a few weeks ago, it's a bigger lesion than this, has now been resected, and the path is being reviewed and re-reviewed and so forth. So hope to have a definitive diagnosis on that soon. But the early markers were not positive for the expected markers in chordoma, so it may not be a chordoma, despite the fact that it shares so many appearances with this case of proved chordoma. Okay, that's the only case I
All right, thanks. That's
mobilized.
impressive. So it's kind of a slowly growing one, huh?
Yes, but relentless.
Yeah. All right, I have just two quick cases this week. I think this one we've seen at least one example of, but why is it not sharing? There we go. This is just an uncommon anatomic variant that usually has no clinical impact unless you're doing some sort of cardiac work. So this was just something I incidentally found, and you'll see here at the inferior pulmonary veins, there's this common ostium posteriorly. And the real importance of this is if you're going to do a pulmonary vein isolation or ablation, or if you're going to do any kind of lobectomy, just because, you know, normally if they do an intrapericardial, or if they do a lower lobectomy, they take the vein, and you could staple a little more proximally here, but you just got to be careful, know about this before you go in, so you don't take out both veins and infarct the other lower lobe. And of course, if you're going to do a vein isolation and they do the mapping, they would see this, but it's just an uncommon variant. I don't know, Seth, you may have a better sense of how common this is, but I found a couple case reports. They said rare. I know I've seen it, probably never thought much of it, but this was a contrasted study, non-distorted anatomy, so I thought I'd save it. So it's called a common inferior vein confluence.
Yeah, I've seen ones where it's almost like you have all four, and it's not a congenital, you know, patient, it's not a TAP or PVR
Right.
correction, but all four go into a single, like, posterior little vein that then goes into the main portion of the left atrium. Yeah, we see it. I mean, I think I saw my first case, I don't know, during a multidisciplinary conference probably 14 years ago, and you just see it every once in a while.
Right.
Yeah.
I don't think it's rare. I just think it's uncommon, and probably something we don't pay a ton of attention to on a non-contrast, whatever, follow-up or something. But yeah, just
So
want to be aware of it.
Seth, when all the vessels conflude and then go in, you know, form a separate little chamber that connects to the left atrium, isn't that just cor triatriatum?
Well, right. So do you call it a cor triatriatum? Well, there's no real band of tissue. I mean, there is a little waist, kind of like there is here, but there's not like a band that extends along that truly separates out like I usually associate triatriatum with.
Okay.
I just think it's some sort of, I don't know. But it is, I mean, I understand what you're creating, because it's creating almost two chambers, but it's not an obstructive process, although cor triatriatum doesn't have to be obstructive. But I don't, yeah, that's a good question.
Yeah, this one's just the inferior veins. You can see the other veins come in their normal places. But yeah, they're sort of like, it's almost like an antechamber here. So, okay, that was one. And then this other one's just a neat technique and something I've never seen us do before. So this patient has chronic kidney disease, is on peritoneal dialysis, and kept getting a pleural effusion. So they were worried about a pleural peritoneal fistula, which, okay, I'm not sure what would cause it, because as far as I could tell, there wasn't any history of trauma or anything, but there are those normal pathways between the peritoneum and the pleura. We see lymphatic drainage, we see pleural effusions with a lot of belly stuff. And so what they did on the technique here is they injected the peritoneal dialysis catheter with contrast, and then they waited, and then they scanned the patient. So you can see there's all this contrast here floating around in the belly. And then what's kind of cool is you'll see there's same contrast here in the pleural space. So it's like a fistulogram, but we've made a diagnosis of a pleural peritoneal fistula, and where the communication is kind of tough. There looks like there's a little bit of contrast right here, tracking along the inferior vena cava down there, but I'm not sure I can convince myself it connects. I think that may just be up in that little recess and not truly communicating there. But I mean, that explains why a patient with peritoneal dialysis would get pleural effusion. You put the fluid in, you dialyze it out. But if you're, and a lot of times they do it when they're asleep, right? So if you're lying supine, some of it could traverse the diaphragm and stick around in there. And what you do about it, I have no idea, but it's kind of a neat technique. I'm sure it's nothing new, but I've never seen one of these before. I don't know if any of you have ever seen this done or ran into these fistulas, if they do anything about them. I came across it from our thoracic surgery group, and I don't know what they have planned, but I mean, if there is a tract, it's so tiny, I'm not sure that you'd ever see it anyway. I'll take that as a no.
Jeff, you had a radiographics article on this recently, right?
Me? On transdiaphragmatic, yes. We talked about the pathways, the normal little, we looked at particularly spread of disease, and right, that's why you see pleural effusions a lot with things like pancreatitis, cholangitis, and then like the route, often those cardiophrenic nodes get plump with liver disease. So I suspect, but this one was enough that the patient was getting an effusion, but it may be the artificial volume of ascites because of the peritoneal dialysis. Because it wasn't a problem until they switched to peritoneal dialysis.
Jeff, what is the mechanism for ascites causing hepatic hydrothorax?
Well, there's a lot of, there's the different things. What I understand is there are lymphatic channels that go through, and there probably are channels between the diaphragm, on both sides of the diaphragm, that allows fluid to get in there. It's probably, there may be some shunting having to do with it, because you get more flow through the systemic veins and lymphatics, and if because you'll see like a dilated azygous vein or thoracic duct, so potentially there's some backflow into the pleural lymphatics. I think there's a lot of different proposed mechanisms. I don't know what it is for certain.
Mm-hmm.
But given that it seems to mostly be on the right, I would suspect it's probably more transdiaphragmatic flow than pressure, because you'd expect if it was a pressure gradient, you'd see it on both sides.
Well, I do. You can see it on either side. It can be predominantly left. So, in the old days, people used to say, well, we know that there are all these fenestrations in the diaphragm, but the point is that diaphragm is covered by peritoneum on one surface and it's covered by pleura on the other. So even if there's a lattice of tissue there, it's not as if there are macroscopic holes in it.
Right, and there's probably lymphatics that bridge them as well.
Right, and we don't see pneumoperitoneum extend to become pneumothorax.
Right.
So we know that there's actually there's a good barrier there. So lymphatics is probably the best mechanism.
Yeah, and we see that. We see that a lot. If you look at like your pancreatic cancers, your cholangiocarcinomas, or like colon cancers that involve liver, the best place to, one of the first places I look for lymph nodes are the cardiophrenic nodes. They're ones that often get missed because, they're down in the corners, you're looking in the central mediastinum, but knowing that pathway. Whereas if you look at like some of your pelvic tumors, like or like, GU tumors, like bladder and prostate and testicular, and some of like ovarian, a lot of times, ovarian's tricky because a lot of times there's peritoneal disease, but let's say if there's not, what I think of is the tumor cells hitch a ride in the lymphatics, and they sort of march up the the thoracic duct, and you'll see those paraesophageal nodes and those sort of posterior mediastinal nodes, and sometimes they'll skip and go all the way up to the left supraclavicular fossa, and you'll get a Virchow node, and that's how you get those skip ones, because I suspect it goes along the thoracic duct. So knowing those pathways can be very helpful. You kind of got to check everywhere, but knowing where the likely places are if you see those nodes. And of course, the cardiophrenic nodes will then march up the anterior chest wall along the inferior internal mammary nodes. So we'll pick up internal mammary lymph node metastases from cholangiocarcinomas that if you're not looking there, it's very easy to overlook that area. So that's the way I think about it. Sort of upper abdominal peritoneal tumors, I think more anterior, and the more retroperitoneal deep pelvic tumors, I tend to look more posteriorly first for those lymph node change. And those are the ones you want to look carefully. Are they slowly getting bigger? Because that may be a metastasis. But yeah, I think this case, I mean, this was, I believe there was an hour between the injection of contrast and the imaging. So there's probably a lot of diffusion across that membrane and through the lymphatics maybe is a better mechanism.
By the way, Jeff, do you see any contrast in lymphatics on this, on cross section?
We can look.
Let's look posteriorly behind the
And there's
aorta.
thoracic duct right there. We don't see anything. They only did an abdominal CT, but we can look at those. And you can see there it is. There's the posterior peritoneal reflection. So you can see it nicely outlines the anatomy. I mean, it's almost like there's the pancreas. So you can see there's the posterior peritoneal reflection, but you don't see it getting into the lymph nodes at this point. See, there's the catheter they injected.
How about diaphragmatic nodes above the diaphragm? Any?
Yeah, I mean, there's a cardiophrenic node there, and you see them up.
But not bright.
No, they're just normal. So this would argue against, I mean, but it's only been an hour, but it still argue against the lymphatic drainage in this case. So there presumably is a communication, but we just can't see it.
Got it.
Jeff, can you scroll down a little bit lower towards the pericardium? Here, a little bit higher up, right there. You think there's anything going? Because then in your paper you were talking about a area that communicates with the pericardium, like around
the central tendon of the diaphragm is fused to the pericardium. So, you know, we've seen cases of like herniated liver into the pericardium when you tear that diaphragm, and I've seen tumor grow from the liver into the pericardium.
Yeah.
But yeah, that's going to be sort of the we see that better on the coronal, under the undersurface. This area in here, the parietal pericardium is fused to that central tendon, and so sometimes you'll see like I know we've shown at least a couple of cases over the years of liver herniating into the pericardial space through that tear, but it's an unusual place for a tear because it's pretty thick. It's protected. And then I've seen cases of tumor like metastases in the liver invading through, but that's because the pericardium is so tough. But occasionally you will see like a really aggressive tumor just march right through there. So
yeah, I think what I've noticed is whenever there's inflammation, the flow becomes a lot more common or more easier. It goes through much easier.
Yeah.
Inflammatory stuff.
Revved up lymphatics or breakdown in membranes.
Yeah.
It's a very interesting, it's a very interesting topic, and the one that sort of bridges the chest and the abdomen. And when we started talking about that, when we were putting together that exhibit and we started looking at cases, we started realizing just how important it is to understand those drainage pathways. And there's some nice illustrations in there that sort of, I think, really do a nice job showing them. But it's not perfect every time, but if you just even know where to look, you'll be surprised how many metastases or disease processes you'll pick up. And sometimes you can sort out which way the process is going to. Is it coming from above and going down, or vice versa? In my experience, it's more often the stuff in the abdomen goes up into the chest rather than the other way around. But maybe it's a selection bias because I'm starting with the chest.
So Jeff, who's the first author on that paper, and when was it published?
It was my former fellow Ruchi Sharma. I want to say it was published in 21 or 20. I can send it to you.
Okay.
Yeah, if you go into radiographics, and my name's on it, Chris Meyer's name's on it, any of us, if you just search us, you'll find it. But Ruchi, R-U-C-H-I, last name S-H-A-R-M-A, is the first author. And she was a former fellow in 20 and 21.
Thank you.
Okay, well, that is all I have. I think that's everybody on. So we'll end a little early today. Great discussions and cool cases, and now I got to watch for more GPA because it is a sneaky one.
Thanks, everyone.
Yeah, bye.
Thanks,
Talk to you next week.